And welcome to the Dr. Bob Show. In the United States, we do an excellent job of finding and detecting cancers early. And when we find them early, the cure rate or the survival rate improves dramatically. But there is one cancer that's prevalent in the United States that we can actually prevent. We can keep it from occurring. That's colorectal cancer. And we'll be spending most of the time on this show talking about how it can really be prevented and what we have to do. My guest is Dr. Raj Narayani. Dr. Narayani is a board-certified gastroenterologist, stomach specialist, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we're going to be talking about heart failure, what causes it, and what can we do about it, and knee replacements. Are they the same for everybody? Are men different than women? Are the sizes of the knees different? A lot of information. You'll enjoy hearing about that. We're talking with Dr. Raj Narayani, board-certified gastroenterologist, stomach specialist, and we're talking about cancer of the colon. Raj, welcome to the Dr. Bob Show.
Thank you for having me again.
So tell me about cancer of the colon. Is it a common thing in the United States?
It's actually very common. It is the third most common form of cancer to develop in people in the U.S. It's the second most common cause of cancer death for men in the U.S. and the third most common cause of cancer death for women in the U.S.
To me, that's a terrifying statistic that it leads the league almost in both men and women as causing death. And yet, to me, it's one of the cancers that we can prevent. Is that a correct statement?
Absolutely. And the reason that we take pride in knowing that we can prevent colon cancer, let's say as opposed to some of the other cancers that we detect in individuals, is because cancers of the colon follow, in most cases, a pathway of development from a simple polypoid lesion to a full-fledged growth over many years. And so by examining the colon earlier in life, usually starting around the age of 50, we can find these polyps and actually remove them with our instruments before they have a chance of transforming into a full colon cancer.
So those lesions that we see, they're called what?
They're called polyps.
And are there different types of polyps in the colon?
There are some polyps that don't have the mutations in their DNA that you see in other polyps, and those that don't have those tend to behave more indolently, more slowly. They don't grow as much, and they sometimes don't become cancer. Other polyps that have these mutations, we call those precancerous polyps. They can, over the course of sometimes 7 to 10 years, become a small polyp to a large polyp to a colon cancer.
How long does that take usually or statistically?
So it may depend really on when you see the polyp, how big it is. So the bigger the polyp, the shorter the time frame that it's going to take to get to cancer. But the average is about 7 to 10 years.
So it's a significant length of time. It's not enough significant length of time for somebody to put off getting their colonoscopy there. At what age do we tell people we prefer they start getting colonoscopy?
For most individuals who don't have any risk factors for colon cancer, usually in the form of family history, we tell them to start at age 50. And that's when most insurance companies will cover the procedure as well as a preventive health benefit. If a patient has a family history or other risk factors that increase their chance of getting colon cancer, they're often told to start earlier, usually at age 40.
If I had a brother who had colon cancer at age 38, then you would want me to get one earlier.
Correct. In fact, if it's a very young family member, then the guidelines would actually tell you to start around 5 to 10 years before that family member's age. So if it was a 38-year-old brother, you might start around age 28 or 30.
What are the symptoms that somebody has if they have colon cancer?
The most common symptoms of colon cancer actually are no symptoms at all. Patients will often tell you they feel well when they're diagnosed with their cancer. But if a patient's going to have some physical symptoms, it may be in the form of rectal bleeding because the tumor is fragile and it may shed some blood or some tissue into the stool that may show when the patient has a bowel movement. Sometimes patients will indicate change in their usual bowel pattern or the appearance of their bowels, even if it's without blood. And then on occasion, but not that commonly, patients may have abdominal pain.
Weight loss?
Weight loss can be a symptom of colon cancer, but typically if it's more advanced because the cancer is now large or it has spread to other places.
When you look and you see a polyp on colonoscopy, what does a polyp look like?
So polyps can look different ways at different times. You can see some polyps that are very flat and indistinct, and we're lucky now because the optical technology of the scope instruments that we use to look inside the colon have changed dramatically over the last 10 to 15 years.
How have they changed? What do? They focus in better? They magnify better? What do they do?
So the capabilities mainly speak to the resolution of the lens and the optics of it. So we call them high definition scopes now, so we can see detail in the lining of the colon with greater clarity. Many scopes have technologies built into them that allow us to see polyps slightly differently by changing the wavelength of the light, and then the lighting of the scope is better as well. And so by having these capabilities in our scope instruments, we can often see these indistinct polyps better than maybe we could back in the 1980s and 1990s when the scope technologies were older.
Do you remember looking through the scopes in the 80s and can say, wow, is this an improvement now?
It is. It's remarkable when you think historically about what we used to do. The scope instruments used to have an eyepiece that you would look through rather than a visual depiction on a screen. And I remember using that kind of instrument when I was a trainee. Thankfully, I've grown up and become a physician in the era where we can use a TV screen now and have the image quite larger than it used to be. So,
when you do a colonoscopy, how long is the colon, and what do you do when you're trying to visualize? I didn't realize how important it was, not just looking when you go in, but looking when you come out. Talk to me about that.
So the colon is typically around 3 to 4 feet long in most adults. There are some people that have extremely long colons, but usually, magically, the colon fits in the abdominal cavity regardless of its shape and length. And the ability to visualize both on insertion and on withdrawal is very important because there are times when the colon may be shaped a certain way when you're pushing the scope in, but it's shaped a little differently when you're coming out because you've reduced some loops or shortened the absolute length of the colon with a telescoping maneuver. And so experts will tell you that a good gastroenterologist or a good endoscopist should be looking on the way in and on the way out. The emphasis of examination is on the way out, though, because you're able to, when you're doing that, pull back folds, remove fluid from the colon, basically clear the lining of the colon to a degree that would allow you to see as much as possible.
Is it common to see a polyp when you do a colonoscopy? If you're going to do 10 colonoscopies over the next 2 weeks, how many of those 10 will you see a polyp?
If it's a man, if it's 10 men, you might find 5 or 6 patients with polyps.
So it's pretty common?
That's correct. It may be one polyp or many. If it's a woman, it'll be 4 to 5. It's a little less common in women than in men to see polyps.
So when you see that polyp, what do you do about it?
So our goal whenever we do colonoscopy is to remove any and all polyps that need to be removed, polyps that are clearly precancerous or might be precancerous. And the methodology by which we do that is fairly simple. If it's a real small polyp, we can usually just grasp it with a forceps, a little pinching device, and just pluck it off. You might need to do it in 2 spots in order to get the whole polyp, but that's a standard technique for a very small polyp.
Does it tear off? Does it bleed? Does it?
A little bit. It bleeds a little bit, but then it stops very quickly for most people who have normal clotting mechanism.
Keep going.
For slightly larger polyps, the technique involves passing a device through the channel of the scope that opens a wire loop, and that wire loop can basically surround the polyp and then shave it very superficially off the wall of the colon, which is very nice because you don't actually have to cauterize any vessels or do anything advanced to that lesion.
Is it easy? No, I won't say is it easy. Can you effectively take out a polyp without too much trouble?
Absolutely. Polypectomy and removal of polyps generally can be accomplished in almost all cases. There's a rare case where a polyp is either too large to remove safely or it may be in a very difficult location. It may be hiding behind a fold that you can't really access with the way you can maneuver the scope. And in those cases, the patient may have to go to surgery to get the polyp removed, but I would say easily 99% plus of cases we can get polyps out.
So if I was 50 and I had my colonoscopy and there were 2 polyps and they were both removed, when would you recommend I had my next colonoscopy?
Great question. So if the polyps were small, but they were precancerous, the typical time frame we would recommend, which is based on guidelines, is 5 years for your next colonoscopy. If the polyps are 10 millimeters or larger, then the typical time frame in that circumstance would be 3 years, because the larger the polyp, the greater the risk to the patient for forming not only colon cancer out of that polyp if you don't remove it, but also other polyps in the colon in the future.
If I was a nervous patient and I had cancer phobia and I didn't want to wait 3 or 4 years, would it be okay to have one again 2 years later?
It would be okay to do it, but we have to be careful a little bit about overutilizing the colonoscopy because there's risks related to the procedure as well. The risks are very low, but we try to educate and emphasize to our patients that these lesions are very slow growing, and because that's the case, if you waited 3 years or 5 years like the guidelines suggest and the quality of your first colonoscopy exam was excellent, then you're likely safe to wait that long.
Are there other things that we can do other than colonoscopy to help detect colon cancer?
So there are other tests that have either...
And that's what we're going to be talking about when we come back. There are other tests that we can do something about. We'll find out how effective they are, how sensitive they are, and will it take the place of colonoscopy? I don't think so. We're talking with Dr. Raj Narayani, board-certified gastroenterologist. We're talking about colon cancer prevention by colonoscopy, finding a polyp and removing the polyp. Polyps have a natural history. They eventually develop into cancer. If we can get the polyp before it turns into a cancerous lesion, we prevent it. And so there's no reason that we cannot prevent colon cancer in most people, let's say 95% of colon cancers. Would that be a good statement?
That's correct.
So when I was 50 and I had my colonoscopy, we're talking about, they didn't find any, but let's say we found 2 polyps and I came back 3 to 4 years later. Could I feel pretty sure that I didn't have any cancerous lesion in there? Maybe some new polyps, but I didn't have cancer because it'd been 3 years?
Absolutely, and that would be a common scenario. You would typically expect that you might have a polyp or 2 because you had some before, but most people, if their first exam was a high-quality exam done by a qualified physician, will not have a cancer at their follow-up exam.
You say high-quality exam by a high-qualified physician that does this. I think those are very, very key words because the prep has got to be good, the examiner's got to be good, the looking when you go in and looking when you go back. In your all's practice, and you have a large gastroenterology practice, do you document the polyps and the accurateness of your doctors?
Absolutely, and we actually track this as a quality metric in our practice. This has become a very big point of emphasis in the specialty of gastroenterology. The ability to look across the population and determine how many patients you're finding polyps in and whether that meets or beats national norms. And so by doing so, we can measure ourselves, we can look in the mirror, we can determine if we're doing a good job or not doing a good job, and then act on that information. And speaking to the quality again too, we look as well at our quality metrics for prep quality for our patients because that's an important part of this. If we can see well in the patient's colon, then we can find things.
So all of that is, it all goes together for a good quality exam is very, very, very important. Let me switch gears. What's a Cologuard?
So Cologuard is a new catchphrase. It's a relatively recently developed test that carries the original idea of measuring something in the stool to detect colon cancer, which we used to do as a hemocult to look for blood in the stool. And now it takes it a step further and it looks for other factors that you might find from colon cancer. In this case, basically multiple targets for DNA. So you're looking for DNA from cells that might exist in a colon cancer that have been shed from the cancer into the stool and then measured on a stool sample that the patient would provide.
So to me, this is a big difference from doing a colonoscopy looking for polyp, removing the polyp. Here you're really looking for the shedding of a cancer that's there. and it's in the stool, and you find it, and then you know you got to go look.
Correct.
Is that correct?
That's correct. And so anybody that submits a stool Cologuard sample and has a positive result then has to follow that with an attempt at a colonoscopy to look for potentially a cancer or a polypoid lesion that needs to be addressed.
To me, it looks like the horse is already out of the barn. You know, you've already got the cancer there. If you find a positive specimen on a Cologuard, that means perhaps you didn't have a colonoscopy when you should have, or something along that line. Now, how good is a Cologuard?
So Cologuards are fairly accurate, and respectably speaking about the stool collection process, they have very good data backing them from that standpoint. If you're not going to directly look at the colon and you're going to do an indirect test, they're reasonably accurate. We know from large studies that have been published that there is about a 7% false negative rate.
False negative rate.
So that means that if you have 100 patients that are diagnosed with colon cancer and they all had a Cologuard at some point beforehand, in 93 of them, their Cologuard would have been positive, leading ultimately to the diagnosis of colon cancer. Whereas in the other 7 patients out of that 100, they would have had a negative test, leading them potentially falsely to believe that they don't have colon cancer, and that's a little troublesome.
Bottom line to that would be you need to follow the guidelines and have a colonoscopy on a regular basis.
Certainly when you're young, I think that's a good choice. I think if you're going to look at Cologuard, you want to know necessarily what the right population would be. We know that the Cologuard test is FDA approved for patients who are considered average risk. So no prior history of colon polyps, no family history of colon polyps or colon cancer. At the same time, if you're young and you're healthy, you're 50, 55, you may still elect to do a colonoscopy because you might be able to tolerate that test a little bit better. If you're going to reserve a Cologuard, maybe for a patient who's in their mid to late 70s, isn't interested in doing a colonoscopy anymore, but has never had polyps before, that might be a target population to consider it in.
If you're doing a colonoscopy and you're looking for polyps, and you look in and there's something that looks like it might be a cancer, what's that look like?
So as opposed to a polyp where you would have a smooth surface lesion that's either flat or slightly raised, a cancer will be bigger and it will be a little...
How big?
So typically between 2 and 3 centimeters, which I would tell you is between 1.5 and 3 inches.
Yeah, so about as big as the end of my thumb-ish.
Correct.
Type situation. And what's it look like? Can you actually feel when you put the scopes over a lesion?
You can. In fact, what we usually do is we try to feel it by using a biopsy device through the channel. Mm-hmm. When you push it from the outside, but you're feeling the tip on the inside touching the lesion, you can tell if it's soft or hard. Polyps will typically be soft and fleshy, and tumors will typically be harder. And when you biopsy them as well, the lesion will bleed a lot more easily. It may bleed more than usual. And there's a look to these lesions often that you can tell. There's an ulcer at the base of the polyp. And that's a tip-off. Sometimes it's already become a cancer.
So if you have a colonoscopy and polyps were removed, feel very, very good about it. I follow the guidelines. If you did detect a cancer, what's the algorithm then? What's the path that you follow? We found some cells, they're abnormal, now we're going to have to do what?
So if you find a cancer during a colonoscopy, typically the gastroenterologist or endoscopist that does the examination will mark the site where that lesion is, even if they're not sure it's a cancer, but they think it might be, so that if there is a surgical need in the future, the surgeon can identify where that lesion is, because they're always looking from the outside in rather than from the inside out like we do. The other things that need to be done for a patient who has a colon cancer diagnosed are really to stage the lesion, to find out if there might be lymph nodes involved, or to find out if the cancer has spread to other organs, because that impacts not only the prognosis for the patient, but also the treatment choices that are available to them.
Is your ability to stage the cancer to see if it's spread, to see what the lymph nodes are like, is it pretty good?
It's reasonable for patients when you're looking for distant spread. For lymph nodes, it can be a little harder. CAT scan technology, for example, is reasonable but not great at identifying lymph nodes. If it's a rectal cancer, we do have scope technology that can see through the wall and actually look at the lymph nodes outside as well to see if they're enlarged and even biopsy them sometimes. But that technology is really limited to rectal cancers only because they're close to the bottom. Higher up into the colon, you're still relying mainly on CAT scan and then surgery to tell you if the lymph nodes are involved.
As I'm listening and learning, I'm sitting there saying, you know, to not get colonoscopy would be wrong. So I'm hoping that everybody that listens, talks to their doctor, gets a good prep, gets a good colonoscopy by a good examiner. Raj Narayani, thank you for coming to the Dr. Bob Show.
Once again, I appreciate it. Thank you.
Great teacher, great information. Wow, is what I say at the end of that. Now you're going to want to stay tuned. We're going to be talking about heart failure. 5.7 million people in the United States have it. And we'll be talking about knee replacement. Are all replacements basically the same? No, they're not. And we'll see if we can figure out why. I want to thank Dr. Raj Narayani. Wonderful discussion on preventing colon cancer. Talk to your doctor about your colonoscopy. Be sure that you get yours done. And now for questions from you, the viewer, that I think will be important to your health. Dr. Bob, what is heart failure? That's an excellent question. The heart is a muscle. It's about the size of your fist. It sits on the left-hand side of the chest. It receives blood, sends the blood to the lungs where it captures oxygen. Then the oxygenated blood comes back to the heart where it goes to the rest of the body where it can be nourished. The heart beats about 60 to 80 times per minute. It beats therefore about 100,000 beats every single day. There are some things that can make the heart not beat efficiently, to get tired, to wear out. Coronary artery disease, the heart's a muscle. If the arteries that supply that muscle, the heart muscle, are diseased, then the heart may not get the nourishment it wants. We can have heart attacks, or we can have heart failure. High blood pressure, the heart has to beat against a high blood pressure. Sometimes after many hundreds of thousands of beats, the heart gets tired and begins to wear out. And when that happens, we get shortness of breath with exercise. Our feet begin to swell. We get edema. We get what we call pitting edema. And so those are the beginning symptoms of somebody that has heart failure. Well, what can we do if somebody has heart failure? Well, we can go to the original cause. If it's hypertension, there are wonderful medicines. There are diuretics if you're holding on to fluid. If diabetes is a cause, we get our diabetes under control. There are diuretics to take the fluid out of the way. There are blood pressure medicines, ACE inhibitors, ACE receptor blockers, beta blocker, calcium channel blockers. All of these are made where the heart doesn't have to work as hard, and therefore if it's not as strong as it should be, it will let the heart beat efficiently. There are medicines that will allow the heart to beat stronger. Digitalis is one of those. So there's lots of medicines that we can take if somebody has heart failure. If we get the diagnosis, then there's low-salt diets, there's activity guided by your physician, and there are medications that are guided. So people can live a near normal life with congestive heart failure. If you start getting symptoms of shortness of breath with activity, talk to your doctor about it, see if it's your heart, see if your lungs, see what's going on, and know that treatment can be very effective for you. And now question number 2. Dr. Bob, are there different knee replacements? That's sort of a cute question. It's a very apropos question. Women's knees in general are smaller than men's knees. So they certainly wouldn't need a knee replacement of the same size. And now we have gender specific. So we have knee replacements that are there for men and for women, and knee replacements that have different shapes. They seem to do well, the men and women seem to do better if they have the gender specific knee replacements. There are also different types of knee replacement surgery. The approach to going inside the knee to place a knee replacement are different. There are sparing of the quadriceps muscle, and there are other things during the surgery that are done to make it where the recovery time will be less problematic. So no, knee replacements are very, very effective. We're getting better and better every day. If you're getting where you can't walk down a hill and your knees are hurting when you walk in the mall, You might talk to your doctor. The x-ray may show bone on bone. He may say, about time to think about a knee replacement. That's all the time that we have for this show. Remember those 4 things that we like. Exercise, possibly the most important thing we can do. Regular activity, get your tennis shoes out. Remember, reduces stress, helps us lose weight, helps against anxiety. Get 7.5 hours of sleep. The more we look into sleep, the more we recognize how important it is for total health. If we're not sleeping well, then the body recognizes that, and hormones from the adrenal gland are put out that raises blood pressure and makes our health not as good. So if you're not sleeping well, find out why. Work that out with your doctor. If you're snoring or somebody next to you is snoring, get that corrected. There's lots of things we can do. Start the day off with a good food plan, a good nutrition plan, a breakfast with fruit and fiber. Continue meals during the day. You can even eat 5 or 6 little different meals. It's just that you can't eat a lot of that food. So eat properly, eat less, and get the nutrition the weight that you want. Most of all, what do we like? Is that laughter in your life. I can't tell you how important laughter is, but giggle a lot, laugh with somebody, enjoy yourself, and you'll be healthier.